דוקטור נייל מקלרן, פסיכיאטר בעל 40 שנות ניסיון בעבודה עם מטופלים קשים ביותר, בראיון לערוץ שוברים קשירה, זכויות אדם באשפוז פסיכיאטרי. דוקטור מקלרן מנפץ בראיון את סטיגמת המטופל האלים, אותה שוקדת גילדת הפסיכיאטרים במשרד הבריאות ליצור. Good evening, Dr. McLaren.
Yeah, good evening. How are you?
I'm doing well, thank you. Let's start by introducing yourself, profession, experience, etc.
Well, I'm a psychiatrist, so I graduated in medicine in Perth in Western Australia, 1970, and then I studied psychiatry. And in those days, I started neurosurgery training, but I didn't like it. It wasn't very interesting. So I changed to psychiatry, which was a 4-year course. And I've worked ever since, mostly in the area of military psychiatry, forensic psychiatry, and isolated areas too. So I worked in the northern regions of Western Australia and then in the Northern Territory. And we moved to Brisbane a few years ago.
Mm-hmm. Oh, thank you. Now, recently we were exposed to a case of a 28-year-old woman diagnosed with schizophrenia. The woman, who was hospitalized in a psychiatric institute, attacked a nurse during a psychotic episode. In response, she was shackled 4 limbs by the team for 24 days, during which she was forced to defecate in a diaper and was only washed every other day. All this among other severe restrictions. Her family was allowed to visit her only 3 times a week, 15 minutes each visit. Following a court petition, the woman was moved to another hospital where she was institutionalized with no restraints and even in a half-open ward. No violent episode was reported.
Mm-hmm.
So I would like to ask you, what do you think of this form of treatment for a woman diagnosed with schizophrenia?
Well, I've worked in very tough areas, working in semi-desert regions with the Aboriginal people, a lot of whom didn't speak English, leading a very traditional lifestyle. And I've worked in prisons, I've worked in military mental hospitals, that sort of thing. And I deal with a lot of military veterans from Iraq and Iran, and they are pretty seriously disturbed. Mostly they're very tough men, they're very well trained, and I just don't believe that it is necessary to handcuff people, and that's that. Now, in her case, it does sound bizarre because there's no earthly reason to restrain anybody for 24 days. That's simply not psychiatry. Whatever they were doing was not psychiatry. But the other thing to remember about aggressive interactions between staff and patients is that very often it's got nothing to do with the psychosis at all. It's got everything to do with how they're being managed. And I deal by myself with some pretty dangerous people. Quite often people I deal with are so dangerous that I won't let them go to a mental hospital because I know what will happen. There'll be a huge argument and they will be jumped and trussed up and stuck in a room by themselves and sedated heavily, and then the trouble will start. So it's easier that I deal with them alone. And all too often the staff will say, oh, he's psychotic, but in fact he's not. If you sit down and talk to him, he's simply upset over something that's happened. Maybe he wanted to ring his girlfriend, or maybe somebody stole his cigarettes or something like that. All too often, any disturbance is blamed on the patient, whereas in fact it's generally the system that's causing the trouble. That's my experience.
So, are you suggesting then that prior to any aggressive or violent behavior, there was always a trigger that caused that behavior, and that many times the trigger is the psychiatric way of handling patients?
In the vast majority of cases, that's true. And you have to find out what was the trigger. Now, was the patient upset already upset by, for example, hallucinatory experiences, and then somebody said something to him which triggered him, but in which case that's bad management. You know, people have got to recognise when somebody's upset, and they've got to deal with that at the time and not keep resorting to drugs and restraint. But the woman, there is no justification in psychiatry for shackling a patient to a bed for 24 days like that. No justification. That's all there is to that.
Mm-hmm. So actually, what you are saying is that with the right approach, we can treat any person, including those who are acting violently, without shackling and restricting them?
Yeah. In the overwhelming majority of cases, that is true. But institutional psychiatry is not geared for that sort of work. They are all too quick to order people around. They don't listen to them. For example, somebody says, I want a cigarette, and they say, you can't smoke. And then that's only going to invite trouble. Because he's already agitated, he's already distressed, he doesn't want to be there. And then when some little girl comes along and says, you can't smoke, if you light that cigarette, we're going to put you in seclusion. Well, that is an invitation to a fight. Mm-hmm. I presume the cultures are fairly similar, but there are ways to deal with an agitated person, and there are ways to make him worse. And almost invariably, institutional psychiatry makes things worse.
Mm-hmm. So that brings me to another issue. Actually, we are taking an adult person and we are putting him in a situation where he is forbidden of doing the most trivial things, or at least he has to ask for permission to do them. How does that fit with therapy and empowerment? And isn't it by itself a reason or a trigger for an aggressive way of behavior?
Yes. Yeah, well, if he's got to ask to go to the toilet, he's got to go and ask a girl to go to the toilet. Now, this may be a military veteran, a 28-year-old, well, 30-year-old sergeant, veteran of a number of campaigns, has to ask a little girl, an 18-year-old girl, if he can go to the toilet. That is only going to cause trouble.
Yep, I see. Now, during your years of work, did you encounter patients who were mentally damaged as a direct result of being physically restrained?
No, because it's so rare here. I haven't seen it for many, many years. Now, I've worked in isolated areas, I've worked in dangerous areas. The last time I approved shackling patients was in Darwin, and there we were treating Aboriginal youths from the central areas of the country, so they're desert areas. And these kids had a habit of sniffing petrol. And in those days, there was still a lot of petrol with lead in it. Mm-hmm. And they would get serious levels of lead in the brain. And the only treatment for that is to use drugs known as chelating agents, which bind the lead and move it out into the bloodstream. Now, once that process starts, their brains become severely inflamed. And they are completely, there's no coherent mental function at all. They have no idea who they are, where they are, anything. They have no idea. And they are subject to terrifying hallucinations. And if anybody goes near them, they may just attack out of fear. And so, unfortunately, we had to restrain them. But that was only their hands and not their feet. And we'd stand them up as much as possible, walk them around if possible. But, a lot of them were big men and they were pretty tough. So it was very difficult. But that was the only time. For the rest of it, no, I would never approve restraint of a patient in a bed. I don't believe it's necessary.
Well, but we know that some patients sometimes act violently. So, given your professional experience, what would you suggest as an effective approach for such cases?
The overriding rule is don't threaten them and don't frighten them. Now, mostly when you come into contact with them, they are very frightened. So it is your job to calm them down. And that's your job. That's why you're a specialist, you see. In the old days, we used to be able to get a cup of tea and give them a cigarette and go and sit in the garden alone and or quiet, where it's quiet, and have a talk to them. But of course, you're not allowed to smoke on the entire campus of a hospital these days, which is ridiculous. But there you are. I don't smoke, by the way. And that saved so much heartache. And in 5 minutes, usually, of just listening to them, they're crying or they're really very, very upset, and they're explaining what's been going wrong. So the first thing is recognize the fear that's driving the aggression and talk to the fear. And you've got to calm that down, and you do that by voice and by gesture. And it doesn't matter if they're extremely psychotic. Even if they can't remember what you're saying, you can still talk to them, same as you talk to a frightened horse or a frightened child. And that's how you do it. And you use yourself as a person to surround the frightened person's fear and just calm it down and allow him to see that he's not in danger. Nobody's going to hurt him. Nobody's going to threaten him. And we can sort everything out if we talk about it. And very often they've been apprehended by the police, they've been wrestled to the ground, they've had their hands cuffed behind them, they've been thrown face forward into the back of a police van and transported, quite long distances. And so by the time they come to the hospital, they're not very happy. So it's the job of the specialist to calm them down. But these days, the psychiatrist doesn't sit in the emergency department. He sits several buildings away. And the first person to see the patient who's brought into the emergency department is very often a little junior nurse who has absolutely no idea what's going on, and she's terrified. Now that is just neglect. That should never, ever happen. Or quite often, if the patient's come in, as walked in, or coming with his relatives, he'll be told to sit in the waiting room, and he'll be left there 4, 5, 6 hours. And he'll see people going in and out, and he just sits there. And nobody ever explains anything to him. And then eventually he'll get to see a junior doctor who's rushed off his feet. And then by that stage, it's just everybody's agitated, everybody's angry or frightened. And so all too often the junior doctor will say, well, you've got to do this, otherwise I'll sign an order and detain you. Then there's a fight. And all of this can be stopped if you have properly trained people ready to intercept the patient as he comes through the door.
So actually, the way I understood what you said is that people who become aggressive, at least most of them, is just only look for someone to listen to them, or this is their way to get attention, so someone will listen to them.
No, they're not looking for attention. They're frightened. And that's the big thing, is that you've got to recognize their fear, even if it's a very big bloke covered in tattoos with studs and mohawk haircut who's standing there with his fists raised. You've got to recognize the fear that's driving this. Mm-hmm. A truly aggressive man isn't going to waste his time in a hospital. He's got something to do. He'll have a job to do. He'll go and be aggressive outside. If they get into a hospital, they're frightened. Mm-hmm. That's a good enough rule of thumb.
Mm-hmm. Well, and then to terrorize them, it just makes things worse.
Absolutely. Absolutely. Very often, I will just, if the police bring them in, I say to them, okay, take his handcuffs off and you go and have a cup of tea. And I'll call you when I'm ready. And sometimes they're a bit weird. Mostly they're quite relieved with that. Sometimes they're fairly wary. They say, no, he's dangerous. I say, well, that's, I've got to deal with that. Aggression breeds aggression. That's all there is to it.
Yeah, of course. Okay. Thank you very much, Dr. McLaren, for being with us. It has been a pleasure to get to know you and your attitude towards your patients. I hope your approach inspires many professionals in their work.
Yeah. That's my pleasure.
Yeah, thank you very much.
Thank you. Okay.